Kia ora. My name's Andrew Collingwood. I'm a respiratory physiologist at Counties Manukau Health. I would like to thank the organisers for asking me to speak today. As respiratory scientists, we should be passionate and focused in helping people lead healthier lives and decrease suffering when given the opportunity. And those opportunities are limited in our New Zealand healthcare system. So today, in my 25 minutes, I will summarise two important issues that need highlighting to anyone asking and interpreting spirometry. There is strong evidence, although inconvenient, that contradicts historic paradigms. The definition of dogma is a principle or set of principles laid down by an authority as incontrovertibly true. And I found this quote in my research, and I think it's fitting, as much of what I will discuss has been known about for at least 2 decades. Maybe social media can speed things along. I don't want to wait 50 years to get some of this dogma removed. So here are the results of someone we tested. The symptomatic person pre-bronchodilator is clearly obstructed with a FEV1 FVC ratio at 66. So that's less than the lower limit normal of 72, or less than 70% if you're that way inclined. However, post-salbutamol spirometry is normalized. The percent change in FEV1 is less than 12%. I'm very sure everyone in lung function sees this type of scenario quite often, perhaps even daily. Pre-BD is obstructed, but post is not, with what may be considered an inconsequential bronchodilator response. Granted, my example may be a bit borderline, but there are many that are not so borderline. So how did the reporting physician of the day interpret this test? So the physician said, or wrote, post-bronchodilator spirometry normal without significant bronchodilator response, normal lung function tests. So this is what inspires me to continue to talk about this. We will see asthma guidelines tout the 12% and 200 milliliter rule, where COPD guidelines like the influential GOLD insist only on observing post-bronchodilator spirometry. So the reporting doctor, in a way, is technically correct here if you adhere to those two specific sources. This approach and the use of the word significant to describe the bronchodilator response, or not significant, is a common simplistic way of reporting. And I have no doubt many of you will be familiar with this approach and see it quite often in some of the people that you may work with or in other reports. So what is my problem with this? Well, airways diseases are a continuum. We know this. You don't wake up one day with COPDs or likewise asthma. And I hope to show this binarization of the bronchodilator response and its connotations fails to be evidence-based medicine and potentially causes harm. I feel the physician's comments here are unhelpful, even if it was very quick for them to write and they could get on with the next one. So Dogma 1 is that the bronchodilator response is actually a test. For simplicity here, I'll be referring to FEV1 throughout. In 2015, I presented a talk on the same theme. The year before, I was inspired by the late Brenton Eckert, and what he said to me really resonated with me. He said, question everything, question what does not make sense. And I would encourage all of us to do this. After all, there are tests. Challenge away, especially if you're advocating for the person you just spent all that time getting the test results from. A year later, I recorded the presentation, or pre-Zoom, of course, and you can find it on YouTube by searching bronchodilator response issues. It will come up about third, and the link is here on the bottom of the screen as well. I had many reasons for recording it. My own lab TSANZ accreditation process, where I was trying to defend not doing quite as many bronchodilator responses as you might expect. And also to help reprogram medical trainees as they come through. So I can't repeat that talk, it's about 50 minutes, but I need to cover the backbone of it now. So just to remind ourselves how in 2021, a bronchodilator response is recommended. Here are the current GINA guidelines, these asthma guidelines, and basically you will see changes of 200 ml and 12% in FEV1 is ubiquitous in various forms. There is a caveat, perhaps, 400 ml and 15% increase gives you more confidence, which I have no doubt is true. Another caveat is a positive test is more likely if a LABA or SABA is withheld, and there are some withholding times. There is nothing here about ICS naivety or withholding inhaled corticosteroids, though. A response of 200 ml and 12% after 4 weeks of ICS is considered meaningful, and it even infiltrated its way into the recommendation as a marker of variability. They mentioned the poor sensitivity of it in the variability part, but we're going to see that that poor sensitivity really belongs everywhere. So we need to look more closely at the 12% and 200 milliliter recommendation. One common reference document for it is the ANZSRS interpretation of lung function 2005. I based much of my previous bronchodilator talk on the very studies these statements reference. And I can tell you, when you read the studies and the statements, they're all true. I need to quickly remind everyone of some of the statements. And don't worry, I don't expect you to be able to read these. I'm just highlighting they're all there in that section. One, the first statement, this one's a biggie. The Achilles heel of the whole bronchodilator response. If you repeat the bronchodilator response on the same person another day, keeping all the variables constant, you likely will get a different response. It's a movable feast, and it's a pretty poor attribute for a test. This was really observed in the eyes hold and uplift trials, if I recall. Number two, bronchodilator response has no relationship with challenge tests. They are very different things, and one doesn't infer the other at all. There is no consensus on what reversibility is, and the latest advice is to stop using the term reversibility, which fixes that. Expressing the FEV1% predicted change is better to use, and that's a common theme in everything you read. Number five, this part contains the 12% and 200 ml recommendation, and it suggests it's significant. But if you don't get that response, well, there's other stuff that could be happening. They mention reducing hyperinflation. And very importantly, a lack of a bronchodilator response does not mean people would not respond to bronchodilator therapy. Very clear. Number six, it's never been shown to separate out asthma and COPD. And that is still the reason we get on referrals, to try and discriminate the two. And another statement that just because there is no response, you can still make people feel better with therapy. So I find it deeply ironic that a reference for the significance of, well, the advocates the significance of the 200 ml and 12% is actually a reference for all the things it can't do. So what's new since 2005? Well, in 2012, some results of a population-based study called BOLD were published. And I've put them on this slide here as a summary. And they used over 10,000 adults aged 40 years and older from 14 countries, including healthy never smokers, which were about 3,900. And they had COPD people defined by spirometry and asthmatics. They performed pre and post bronchodilator spirometry on the whole lot of them. And so they determined the distribution of the bronchodilator response. And what I'm showing here is the healthy normal numbers. And they did include values for people with COPD in the paper I'm showing. And they concluded at the end that the results provide reference values for bronchodilator responses worldwide that confirm guideline estimates for clinically, they use that word, significant levels of bronchodilator response in bronchodilator testing. So they simply base this on the upper 95% percentile of the bronchodilator response in normals, and that's around 12%. And you can see the absolute change at 284 mils is actually quite a bit more. Well, this brought on a stinging editorial from some local New Zealand authors, and it's a really excellent read. And I only came across this about a year ago, and I did contact the correspondence author, and Richard Beasley sent me a slide I'm going to use shortly. The editorial focuses very much on what is essentially not said about the bronchodilator response from that bold paper, specifically in the disease groups and how it actually performs. And they must have had enough data to give receiver operator curves. And where's all that information? In the editorial, they concluded that there is considerable overlap in the bronchodilator response in health and disease and between asthma and COPD. And they said in 2012, it has recently been argued that spirometry is an essential tool in patient evaluation, but dangerous for disease diagnosis. Similarly, we would propose that the bronchodilator response testing is interpreted with caution, and that is considered in its clinical context, because large populations of patients with asthma and COPD will have values in the healthy range. So let's look at this in more detail, and this is the slide that Richard sent me, and it's probably the only thing that you need to see, and it will show a lack of discrimination in the bronchodilator response. It shows the FEV1 change in 3 groups: healthy, COPD, and asthma. And note those massive overlaps in all of them, and the Gaussian appearance of the distribution. You would think if the bronchodilator response was picking out something, there would be more bias in one area, or a different, not that normal distribution shape. So here it is, the 12%. I've put it in as a red line. And yes, about 95% of the normals are below this in that bottom graph. They're on the left side of it. But look at where it goes through in the COPD and the asthma. The 12% is really useless at ruling anything in or out. There's no difference above or below this threshold in those disease groups. The editorial bronchodilator response interpreted with caution, however, worked out some likelihood ratios. I'll need to introduce those. They point out for a test to have any clinical relevance as a test, so acceptable in change, it has to be acceptable in changing the post-test probability. A likelihood ratio positive should be at least 5, and that gives you 33% probability of changing the diagnosis. And the bronchodilator response is only 2.5, so quite far away from the minimum of 5. And for negative, 0.2. And the bronchodilator likelihood ratio is 0.9 for that. So although the 12% is towards the higher healthy people's variability, it's only in the middle of the disease ranges and cannot indicate disease or separate diseases at all. The only truth that you can see from that is that very large bronchodilator responses above about the 33% increase are associated mainly with asthma, and they are a very small group. There's not many that actually achieve that really high one. So what about other studies for bronchodilator response? BOLD is not the only one. So my colleague Ewan Morris from Watermatter sent me this paper in 2019, and he said, Andrew, this is for your bronchodilator response talk. Well, I've put it into this one. When I read it, my jaws dropped. The authors have performed an entire literature review on the references of every bronchodilator response recommendation in asthma. Well, since it all began. A fundamental of any diagnostic test is to understand its sensitivity and specificity. And even better, these figures, and it's even better if these figures it can work in different circumstances. And even that's really important if you consider asthma is often present in a continuum with other lung diseases, which is a situation faced all the time by everybody performing lung function tests. So I don't expect you to be able to read this, but like many great papers, there are juicy things in the supplementary material, which is where this is from. So I'm showing this just to demonstrate their thoroughness. It's a fascinating snapshot of who recommended what and when and how they express the change in FEV1 and the cutoff of significance when mentioned in those studies. And it seems to have started, I don't know if you can see the top left there, in 1959. The bronchodilator used was adrenaline and atropine in that time. And I tried to find out what the Intermountain Thoracic Society was, but Google let me down a bit. But I found it is connected to the state of Utah. But if you can see from the 90s on, there's lots of 212% recommendations. There's a bit of an echo chamber from then on. And if you look further down, you can see the 15% and 400 milliliters from the GINA recommended. So they also looked at the three main methods of looking at bronchodilator response, which are absolute change, the percentage change, and the percent predicted change in the FEV1, and what guidelines recommended and when. Again, useful for a reference. As we have seen, the distribution of the bronchodilator response in normals and disease is very important to qualify. I'm just highlighting the bold one there just to show you that they did capture it and the numbers all match up to the paper. And you can see easily that the bronchodilator response in other normal studies on this paper as well, in these population-based studies, also reported is the change in percent predicted when it was mentioned. So you can look at different ways of reporting the change. And this slide shows how the normal bronchodilator studies further broken down. It's really just to emphasize how thorough these people were. So I'm not going to do this paper justice because you could easily do an entire talk on it. But in summary, they mentioned there is no gold standard method to compare bronchodilator response to. We know that there's no gold standard test for asthma. It's a clinical diagnosis. Values of the change of the FEV1 above the 95th percentile in healthy population are often considered abnormal. However, and this is really important, it's important to notice that this cutoff only separates healthy from abnormal. It doesn't state what those abnormal values have. It doesn't say if those abnormal values have any particular disease. The change in FEV1 bronchodilator response may be very poorly sensitive in current asthma. In one Danish study, 82% of the asthmatics lacked a bronchodilator response, despite 30% of them having moderate to severe respiratory symptoms. So rubbish test, really. And another study where the inhaled corticosteroids were not withdrawn, and they were very thorough at trying to work out what therapy people were on. In young adults, it suggested a sensitivity of only 13%. And yes, a high specificity, but that's because they were all meant to have asthma. So poorly sensitive. Several studies prefer expressing the bronchodilator response in the change in FEV1 as a percent predicted, or indeed a change of Z score to overcome the influence of age, sex, height, and level of obstruction in the cutoff. And the last one is important, it keeps cropping up. If you are to declare a cutoff, why choose one that promotes bias, especially gender bias? And also, as non-Caucasians predicted in GLI for substantially smaller lungs, we could also add race as we could also add race bias if gender bias wasn't enough. And I can tell you in my lab, we use non-Caucasian predictors half of the time. So the conclusion was there is not enough data to assess the sensitivity of any cutoff for the change in bronchodilator response to differentiate asthma patients from healthy subjects, or to differentiate between obstructive pulmonary diseases and their phenotypes. So it's looking like a real shocking test. What about using the change in predicted FEV1, or indeed the change in Z-score? If we're going to use anything, it has to be this. It eliminates all that bias. And just as an FYI, the absolute change of 200 mil requirement makes the bronchodilator response 2.7 times biased to men. So just a summary, ARTP 2020 lung function statement uses a reference from a 2015 Miller et al. Paper, which I actually discussed in my other recorded lung function bronchodilator response talk, that suggests greater than 8% change in predicted FEV1 as a cutoff. And that paper assumes a survival advantage from people that they tested in a laboratory, which would infer an asthma diagnosis. I'm not entirely sure if greater than 8 means equal or greater than 9 and not say 8.1. It's not clear in the statement even. But Kwanya, many years earlier in 1992, who looked at what's the best way of reporting a bronchodilator response for differentiating lung disease, also came out with the same number of greater than 9. And this one did have likelihood ratios, well, that paper had likelihood ratios published, and the likelihood ratio was 1.7 of that, not if you use 9. And that equates to changing the probability of diagnosis only by around 10%, which is, again, very weak for determining classification of lung disease. You will always be uncertain. So going back to person X and the reporting physician's comments that hit a nerve with me, and I hope everyone, how can we help any of our physicians, colleagues who say are stuck on the binary? How can we convey what we need to do? Well, this is what I think we should write for these types of results. Baseline test pre-bronchodilator is abnormal and of a mild obstructive pattern, which on this occasion normalizes with a SABA. It may not on another day, as the bronchodilator response is a continuous variable. The 8% predicted change in FEV1 may slightly increase post-test probability of asthma by approximately 15%. Differentials include mild or early COPD or asthma, both of which diagnosis can be made with spirometry alone. Clinical correlation is required, and I note they are not on any bronchodilator therapy, and which may be considered for a trial of symptomatic benefit. So I feel these comments are suitable, and more importantly, give permission for treatment and so reduce suffering. Patients can make life choices to minimize harm rather than being told, oh, you're all good. I feel these comments advocate much better for the symptomatic patient. So while I have an audience, I just want to highlight the ARTP 2020 Z-score based severity scale. It has those odds ratios of finding that Z-score in a normal population, and I just find that quite intuitive and nice to look at. So to end on a positive note with Dogma 1, despite entrenched views, with perhaps people and organizations being very much invested in the status quo, there are changes afoot, and I've included some here for any of you to refer to and quote if needed. The first one for primary care spirometry and asthma is probably very useful, as it states categorically normal spirometry and a lack of bronchodilator response does not exclude asthma. Again, given permission for people to have a treatment trial and see if it resolves symptoms and not dismissing it. So my next dogma is not as complex and is directly related to the bronchodilator response dogma. It's that COPD must be diagnosed post-bronchodilator. And this is a mantra in COPD guidelines like gold. This statement from the ARTP 2020 summarizes the initial thinking, which is basically to exclude asthma, and anyone left meeting a definition of obstruction must be chronically obstructed. The ARTP statement also acknowledges what we know, that the bronchodilator response is a continuous variable. So it is questioning the practice of doing everything post-bronchodilator, making that diagnosis. But you can have permission to use, sorry, that should say pre-bronchodilator, permission to use the pre-bronchodilator. Textbooks, not disease-specific guidelines, give us permission, if permission were needed, to use the pre-bronchodilator results this way. And from this well-known textbook, baseline spirometry, also referred as control or pre-bronchodilator spirometry, is generally used as the basis for interpreting spirometry. I wouldn't read any further after that chapter because it is a little bit tending towards the dogmatic. So here is our same patient spirometry again with that comment. And this time I've simply made a few more details, query COPD, and they've got some smoking history. The pre-bronchodilator tests reveal early disease. It provides a stronger signal for the abnormality. So even if subsequent post-salbutamol results are normalized, failing to acknowledge this defeats the object of testing and introduces harm. The signal of disease is there in the pre, and then by our action of administering salbutamol, it's masked in the post. We are minimizing the patient's symptoms by only observing the post. So I believe it's our duty to emphasize the abnormal and also to make sure therapy is offered. Yes, this stuff is longer to write, but so what? It's the actual truth. And while I'm here, a technicality. Spirometry guidelines like the 2019 ANZSRS are very precious about making sure we get accurate predicted values, and even recommend getting height and age to 1 decimal place. And we've seen every normal study, or every study in normals of bronchodilator response, that the administration of salbutamol increases FEV1 significantly. Even more than race choices in the GLI changed the predicted, or some of the race choices. In the BOLD study, if you remember that distribution, the medium looked to be about a 9% increase. So I was wondering as I was writing this, technically for both post-bronchodilator, given that it changes normal values so much, shouldn't we be using post-salbutamol predicted values, which of course we don't have? And wouldn't that be interesting if we then removed the predicted values from the post, because we don't have any suitable ones? So thank you for listening and indeed watching this. It doesn't matter how beautiful your theory is, it doesn't matter how smart you are, if it doesn't agree with the experiment, it's wrong. And that's from a well-known physicist, Richard Feynman. I'd like to point out my t-shirt also has something there, which is reversed, but it says, "Science doesn't care what you believe in." Thank you. And I guess now some discussion.